Good morning. Let's see, Dr. Najjar. I want to make sure I'm saying that correctly. Can you hear me okay? Is
Yes, I can hear you.
that how you say it, Najjar, or how do you say
Yeah,
that?
that's correct. Najjar is perfect.
I got lucky. Awesome. Where are you at today?
I'm in West Hartford, Connecticut.
Very nice. Okay, I've been to Connecticut exactly one time in my life. It'd be a very nice place. Well, first of all, welcome and thank you for taking the time out to do this. I know you're probably quite busy, but I'm sure our folks will appreciate what you have to say today. Can you, by way of introduction, give us a little bit of background on yourself, if that's okay?
Yeah, sure. I'm Christine. I grew up in the Hudson Valley region of New York. I spent my summers abroad in Lebanon. That's where both of my parents are from, and I really kind of learned a love of food and cooking through kind of just being in the kitchen a lot with my family. Grew up with a passion to help people, went to medical school, was completely underwhelmed by the nutrition education I got there. So I got a master's in nutrition while I was doing my clinical rotations, and I did my residency in internal medicine, and most recently got my board certification in obesity medicine as well.
Yeah, that seems to be not an atypical path for a lot of people that are interested in nutrition. They end up with as obesity medicine specialists, because, as you know, obesity is a bit of a problem. Just to understate it, yeah, I think. So I mean, go back to your point about I went to medical school. God, it's been, I don't know how many years ago now. I started in 1990. Well, no, 89. When was that? 89. God, it was so long ago. But yeah, I mean, nutrition was not a major feature of medical school. I don't remember it. I don't remember, obviously you're just trying to memorize as much as you possibly can. And, that's how you do that stuff. But why do you think, I mean, is nutrition even important? I mean, I know this is kind of a silly question, but I mean, why is it so underemphasized in medical school, do you think?
I have no idea. I think it's just like one of those things where, the curriculum was made and set and nobody is taking the time to change it and fix it. I actually became close with one of the professors at my medical school who does the curriculum. And I've reached out to him multiple times to try to like revamp the nutrition course without much luck, unfortunately. And I don't know why. It really doesn't make sense. Like, I pulled up all my nutrition notes from medical school a couple of years ago, and it was like focused on nutrition and pregnancy, focused on like kwashiorkors and how to avoid refeeding syndrome. And I was like, that's not the problem that we have in modern society. So it was, it's really disappointing at the end of the day. And you talk to any doctor would admit that they really didn't get the education that they needed. And you just kind of, clinical rotations doesn't give you that. It's just nowhere, and it doesn't make sense, especially when, our, hospitals, primary care, it's all riddled with chronic modern disease, which, nutrition can play an incredibly significant role in all of that. So it's really a shame. But I don't, I wish I had a magic wand and could fix that. But, the most I could do is try to reach out to these people and see if anybody would take, and, obviously counsel a patient in front of me with what I know in my education, and just kind of be a role model that way, which is one of the big reasons why I started my Instagram account, to just kind of show people what I eat. Like, it's okay to eat the steak. It's okay to eat meat. These aren't things that you have to fear or be worried about. They're actually the most nutritious foods for you. So, yeah.
Yeah, and it's funny because we all, I think most physicians would concede our nutritional education was at best sorely lacking, and yet many people look to us for nutritional advice. I mean, a lot of people. I mean, it's almost part of the duty. Although I think many physicians just totally discount it. I think they've gotten frustrated. They're like, well, whatever I say, no one's going to listen to anyway, and it's, you kind of just, okay, we'll skip that part and go straight to the doing the procedures and prescribing the medications. What motivated you to go beyond? I mean, why, because, I didn't, when I was in medical school, I had no desire to get a master's in nutrition. I wanted to get on to my orthopedic surgery residency and start, dropping nails down people's femurs. I mean, that was the only thing I wanted to do. But so what got you thinking about nutrition, or were you already of that mindset before you went into school?
I really think that was my personal experience. And going to Lebanon every summer was kind of a really key focus in all that, because every time I would go there, I never put myself on a diet. And this is even, from like the ages of 5 to 10, never put myself on a diet, but my clothes would always get bigger and looser while I was in Lebanon. And I'd come back home to the US, and it's like I would gain weight and be like, this doesn't make any sense. And it was just, eating the wholesome whole foods that I was eating over there, the pattern of eating. The biggest meal of the day is lunch. And so you don't have a big breakfast. You don't really have a big dinner. You kind of just eat your lunch, and that kind of focuses it all in. And very much like farm to table. My grandmother had a garden in the back. She'd go to the local butcher every single day to pick up food, or we'd get fresh fish from, the fresh catch from the Mediterranean Sea. So it was a very different food lifestyle. And, like I was saying before, I developed a very deep love of cooking and food from just, the family and cultural aspect of it. And I think that just kind of tuned me in. It just didn't make sense. I saw, Americans get sick. And I remember to this day when McDonald's finally opened in Beirut, and it was like a huge deal. And everybody would lined up to go to McDonald's, and all of a sudden, we're going to the store to buy chips and ultra processed foods and all these junk foods. And I slowly started seeing people in Lebanon get these chronic diseases that Americans already had. And I kind of saw this, like, it was weird. It was like the ultra processed food, giant came now to this like country that is more founded in like ancient, cultural foods. And that really just rung a bell with me, and it just always kind of stayed with me. So I think that was really my push to pursue that even more in my own personal practice.
Yeah, I think what my problem is, I just stayed in Texas. I didn't go home in the summers. I stayed in Texas, in Houston, Texas, where everybody was, everybody just stayed fat. So I didn't get that experience.
Everything's bigger in Texas.
Yeah, so to speak. I went in Mississippi and some of these other states, for goodness, yeah, we were really suffering with that. But so the master's in nutrition, did that come, did you do that during your residency or during medical school, or how did that work for you?
That was me just being really frustrated with not having nutrition knowledge. It was during medical school during clinical rotation. So I went to St. George's University, which does the first 2 years of med school, the book study in Grenada, which was an awesome experience getting to live on the island. Fantastic time. But the clinical rotations are kind of scattered in the US, and I really wanted to, I chose Brooklyn as kind of my main place. And so I knew I was going to be in Brooklyn for 2 years, and I was just researching the internet for other ways I could supplement my education, and came across this part-time program that Columbia University was offering for any healthcare professionals. And so doctors, dentists, dental assistants, nurses, NPs, anybody, like any licensed professional could do it. And while I wasn't yet an MD, I simply emailed the program director, my professor, and was like, hey, I'm in medical school. I really want to do this. It was a part-time program meant for full-time professionals. So I figured, even though I was still doing my rotations and that had to be kind of my primary focus, a weekend course, like once a month, it was really just once a month that I had to go for classes. And if you couldn't make the classes, you could look at it online. And so they let me do it because I had already satisfied the first 2 years of medical school. And it worked out really well. I had all of my class schedule for the entire year. So at the start of every single clinical rotation, if I couldn't be on call for a certain weekend, I just made it work. And I just budgeted my time. And I was excited to read the nutritional literature. And really, I don't know if you remember, but everything you learn in the first 2 years of medical school, if you study it well enough, there's not much studying you need to do the second 2 years. It's really just kind of fine-tuning your clinical skills. So I was a strong enough student to not really have to review much of the medical knowledge, and I could really focus on expanding my nutritional knowledge. And the program was supposed to be 3 years, and it really just worked out that I, during my surgical rotation, became very friendly with the bariatric surgeon, because it was kind of the nutrition roundabout, and he was looking for a student to help with a research paper. And so I was able to take that research paper and make it part of my master's thesis. So it kind of all worked out, and I was able to finish my my master's thesis in that entire program at Columbia in the 2 years, and finish that before residency started. Well, technically, like, I gave my master's thesis during like my first month of residency, so there was a little bit of overlap there, but it really just it just worked out. It was just luck of the draw. I somehow made it work. And that program was really interesting. You know, it didn't really teach me low carb, ketogenic nutrition, carnivore nutrition, but it did teach me like how to navigate like nutritional epidemiology and the science and critically appraise literature. And the irony about all of it is I started medical school as a vegan. And, you know, a year of veganism put my health in horrible condition. My fingernails were falling apart. I just like was hungry all the time. I was hangry all the time. And so by the time I made it to the island, I converted to vegetarianism. And this was just because I had read like the China study, and I had read some of these like books down the vegan vegetarian rabbit hole. And it was failing me, but I, you know, as a pescatarian, I was in okay health. But my master's program, I remember distinctly like getting into arguments with my professor trying to defend veganism and vegetarianism. And she's just like, Christine, there's no good evidence. Like, look at this evidence. It's all food frequency questionnaires. It's all, you know, it's not a solid study. It's still debatable, like, you know, guns still out. And so I pivoted and I reincorporated meat into my diet, but I was still a little bit confused. I was still very much everything in moderation, still very much like on the calories bandwagon. But I still had this new armed like education about, you know, starting to really question everything I read when it came to nutrition. And that's really held fast with me through the rest of my nutrition journey, where I eventually fell into reading, you know, Nina Take-Holtz and Gary Taubes and Jason Fung and a lot of other people who opened my eyes to, you know, really how foods affect your hormones. And that put me on the low carb path, the ketogenic path. And eventually I found this carnivore community because a friend from like childhood knew I was a doctor and kind of an advocate of low carb. She's like, hey, have you ever looked into carnivore? I was like, no. And I joined some of the online Facebook groups and was just like totally flabbergasted by some of the anecdotes that people were talking about. And so I went down the carnivore rabbit hole and was like, wow, this is fantastic. Tried it for myself and just absolutely loved how I felt, and was able to sustain that until I became pregnant and had really like bad meat aversions, and then had to kind of go back to more of a low carb lifestyle. But you know, vegetables don't necessarily do harm to me, or at least I don't feel all of them do harm to me. So I've kind of come to this newfound, like, you know, your health journey is your health journey, and you really just have to self-experiment. And I think that, you know, a carnivore diet and lifestyle is a really great healing tool for some people, maybe not for everybody. And so it's this new, yeah, that's kind of just where I'm at right now, a little bit about my journey there.
Yeah, that's you know, and I think that's very interesting. We've seen a lot of people that come from these plant-based backgrounds, and many people within this community kind of just didn't have very good results on that. And it's always been health related. It's not been sort of an ideologic type of thing. And I would certainly agree with you that for a lot of people, a carnivore diet works well. For some people, it's not the right fit for them, and that's fine too. And we're not dogmatic about this here. We're not trying to save the tomatoes or any type of that stuff. It's just basically about health here, and that's one of the neat things I think I've seen. Let me ask you about so I assume you're in practice doing internal medicine. I don't know if you're hospital based or if you're outpatient, or are you able to successfully use nutrition within your own practice? Is it hard to do? Do you have support for that, or how are you implementing that, or if at all?
I definitely I'm very much, I'll take the time with patients to sit and talk to them about nutrition. Um, I was faced with some challenges from the group that I was working with because they weren't really happy with how much time I was taking with patients to explain. And so, it was a little bit of a bumpy road, but at the end of the day, I mean, I can't tell you the number of times I would write meatrx.com on a piece of paper and just be like, hey, like, just go check this out if you're interested. So there's always, at the very least, books, websites. If I don't have the time myself to give the education, just kind of give some guidance onto where. And, it's really interesting because a lot of doctors, especially in residency, they were, they kind of scrutinized what I was trying to do. They're like, nobody wants to do that. Nobody really cares. The compliance is really low. And I'm like, that's just an opinion. You can't say that people don't want that. And I found that a lot of patients that came to see me were actively seeking out a doctor who wanted to take the time to sit and talk to their patients about health and nutrition and how it all fits together.
Yeah, I'll echo when I was, as an orthopedic surgeon, and when I did my internal medicine residency, I was just always, I don't know if I want to say frustrated, but internal medicine, you write these super long notes and you take all this time and it's really time intensive. Whereas an orthopedic surgery note is patient's not dead, looks good, vital signs stable, out the door. We were very rapid. But so when I went to take the time to try to explain nutrition, that was like the worst thing. It's like the worst field possible because it's high volume, go, operate, do procedures. And so if you're saying, yeah, it's frustrating because I don't have the time to delve into lifestyle and nutrition and other things, you can imagine what orthopedics is like. And it's definitely funny that way. But let me ask you, so, you mentioned you had a plant-based background or vegan background when you entered medical school. There is I guess the American College of Lifestyle Medicine, which is, lifestyle medicine sounds good, but it's largely a plant-based initiative. I mean, that's what that is founded on. And so anybody that says I do lifestyle medicine kind of automatically assumes you're going to be eating a largely plant-based or vegan or vegetarian diet. And that seems to be, they've kind of sort of maybe captured the market, or at least they claim to have a monopoly on that. But that's clearly, we're seeing people on the other end of the spectrum, like, these carnivores and ketogenic people and animal-based people that are, I think, equally getting good results. And then you pointed out when you went to Lebanon, or you probably put that substitute for many countries, the processed foods. I mean, they were eating. I mean, that's clearly the common point.
Yeah.
People lose weight and get healthier on a plant-based diet. Some do. People do the same thing on a meat-based diet. What do they have in common? They're not eating the processed garbage. Why? I just don't understand why we don't have a national dialogue about this. I mean, I just don't see it coming out of the CDC. I don't see it coming out of, any major government organizations that would, or, American Heart Association or, American Diabetic Association. They're very soft on this. Any thoughts as to why that might be, or would you agree that's a pretty reasonable position?
I would agree that's a very reasonable position. And I mean, maybe it's a conspiracy theory, but I think that the food industry has some pretty powerful lobbyists and some pretty powerful influence over the food industry. And it's really interesting when you look at, the history of nutrition and veganism and where it's grounded and founded. And I actually ran into, because I was looking into doing a fellowship or internship with American College of Lifestyle Medicine, and hadn't realized that they were really just like a vegan kind of propaganda scheme until I did a rotation with somebody who represented the American College of Lifestyle Medicine, and he was, prescribing beans for patients and exercise and some, stress reduction and a lot of other good things. But I remember, and this was during residency, so I had already gone through my, vegan experience, my vegetarian experience. I had already read, a book like Deep Nutrition by Catherine Shanahan, which I think is a very well-rounded nutrition book. And you know, I would sit and listen to him nutritionally counsel these patients and keep my tongue really shut. And I remember, like, at the end of the rotation, I was like, hey, you know, maybe you want to consider reading this book. You know, maybe this is a little different than, you know, what you have come to know. And it's frustrating because, especially now with like this misinformation word that's being like thrown out in the internet for everything and anything, you hear a lot of vegans pointing to people who are animal-based or meat-based being like, oh, stop spreading misinformation. And it's kind of really sad because I think you're right. At the end of the day, like, we are both advocates against ultra-processed food. Or at least I like to think that cornflakes isn't ultra processed food. And so it just, the grounds get muddy, and I can't help but wonder if that's because of just money. At the end, you know, our like our tax dollars go to fund corn, sugar, wheat, and soybean, and so those become commodities, and so those become really cheap, and so the food industry can take those cheap foods and make big profits out of it. And at the end of the day, it's really the USDA funneling our tax dollars into those monocrops that's just like feeding this vicious cycle, and it becomes way bigger than any one person could actually, you know, like, how do you break that cycle? It has to come from a government level. There has to be a change within the USDA. Like, who funds the USDA, who's controlling all of that. Those are kind of the bigger answers, and how we're going to come to a better solution to break that vicious cycle. And it's just a cycle. It's not, you know, as an individual doctor, neither I nor you can really do much other than counsel the person in front of us, try to, you know, get these communities up and going. But you know, we don't get to choose where our tax dollars go. Like, I would rather go to like the local farmer or something like that to build a more sustained community around where I live. But that, you know, it's out of our hands.
You know, I think there are things we can do individually and collectively that may not involve the government, and, you know, certainly, you know, exercising your right to vote and being active in those can be part of that. But I mean, there's things we can do outside of that. But let me ask you, so you get a master's in nutrition. I can't imagine the course that the coursework you took was saying that meat was the healthiest food you can eat and red meat is good. And I mean, I'm sure that was the same thing, that, you know, we should limit it and, you know, just eat a little bit of lean meat and so on and so forth. So how do you reconcile not necessarily prescribing that or you know, having faith in that particular belief system? I mean, is that fair to say? Was a nutrition?
I started picking up on some weird, you know, kind of contradictions, you know. So we would read some studies, and at the end of the day, red meat and saturated fat, when we looked at the studies, they were neutral. But then when the dietitian would come to give her like what everybody should be eating, a healthy diet, it was, as you're saying, limit the red meat, eat the beans for protein, and, you know, focus on, you know, basically a plant-based, the my plate agenda. And at the same time, for example, we got like one article on ketogenic diets, and that was the first time I'd ever been introduced or even heard that word. And the article it was remarkable. It was like, oh, this could fix diabetes, it can fix blood pressure, it could fix acne, it can fix this. And it's citing a really good study. It was like a review article, and I was really curious about it. And my brother, who's like kind of really big into the biohacking community, had already become ketogenic and was already like eating the bacon and eating the butter. And I was like, I don't know, man. In the hospital, when people come in with heart attacks, like, they still go on low fat diets. There was this conflicting views, and I didn't really know what to really make of it. And it wasn't until I started reading, you know, things like Deep Nutrition, talking about more ancestral diets like Primal Blueprint, where I just kind of was like, it doesn't make sense. And so I kind of coined this like 200-year rule. Like, if it existed over 200 years ago, it's safe, it's healthy. If it's more modern, it's probably not. And so I guess like, you know, a lot of what I learned in that master's course is like, to me, like kind of garbage. And so that's why I like, you know, honestly, the most important thing I took from that program was how to pick up an article and say, you know, this is an article, this should really be hypothesis forming. This is something I could make a recommendation from. Like, I don't think that as physicians, we should be making nutritional recommendations based off studies that use food frequency questionnaires, because it's not an accurate source of data. So I, you know, kind of like in medical school with the nutrition advice we got, you know, it wasn't, you know, very great. And so there was some not so great nutrition advice I got from the master's program. And, you know, at the end of the day, it's about what makes the person in front of me feel better. And that's it.
Yeah, I think that last sentiment to you there, and I've talked about this many times. You know, at the end of the day, why does someone come to see a physician? Because there's some problem, they feel bad, there's something
Right.
wrong, and they want it to go away, they want it to get better. They're not necessarily coming to you so they can live to 100. I mean, I at the end of the day, and I think, you know, honestly, I don't know what diet's going to make you live to 100. I don't think the data is knowable. I mean, I just don't think you can perform those studies. And so if we recognize the limitations of nutrition when it comes to longevity and what I'm going to die of in 30 years, then I think our job becomes, how do I make a sick person not sick? And then when you look at the nutritional tools you have, some things rise to the top and some things don't. And you know, in my experience, I got a lot of people in this community that were sick, really sick, and now they're not. And I think that's pretty cool. You know, do you get so obviously, you know, I just took a peek at your Instagram and you got pictures of steaks and meat and, you know, some other foods in there, but do you get a lot of pushback from colleagues, from people around you, that people think you're just a bad person because you're uninformed or uneducated or something along those lines, because you're not necessarily recommending the MyPlate or the plant-based diet?
I have, it's been interesting. I had, you know, at one point when I was posting, like I had a post once that like red meat is a superfood, and that was like the caption. And I had somebody I'd gone to medical school with who was, I think, working with like a vegan cardiologist at the time, like blow up my Instagram with, what about TMAO and this and that? And I just was like, this isn't the venue for it. I've gotten a lot of weird looks from like people at work. Sometimes I'll just bring like hamburger patties or just like eat protein for lunch, and nobody really like questions it to my face. So I don't really know if they if they do it like, you know, behind closed doors. There are definitely like some vegetarians that were in my office, but it, you know, I seem to just, whenever somebody kind of questions what I have to say, I always just bring it back to the literature. Because there's a lot of literature to show that, you know, you could prove really anything you want. You want broccoli to be a superfood, or do you want it to be a death food? Do you want meat to be a good food, or do you want it to be a death food? And you could argue either perspective. So it always comes back to, or at least I always bring it back to, well, what makes you feel good, you feel healthy. And yeah, I don't know if that answered your question. Sometimes I get, you know, I haven't really gotten much pushback to my face, I guess, but I'm sure people are cursing me behind closed doors. And, you know, I was always that girl who kind of didn't, you know, follow the drum line per se in residency and did her own thing. And some people have told me I'm known for that, and I'm okay with that.
Yeah, I mean, sometimes it takes people to push the boundaries to make a change, and I think that's, you know, we see some of these people that are, you know, doing extreme things, and then that's how sometimes the entire thought process change. I mean, you know, when I was practicing, you know, I would take the entire office out to eat barbecue. I mean, we go to the big barbecue restaurant. I'd eat, you know, I'd put down 2 or 3 pounds of meat, and everybody, you know, 10 people I'd take with me, I'd buy them all lunch, and we had a great time. So no one thought I was strange, because maybe I'm a big old guy and I'm supposed to eat meat. But I mean, there's this kind of weird perception that men can eat meat and women shouldn't, or some silliness like that. But let me ask you about, so you brought up TMAO, you know, and you said it's not the venue. What are your thoughts on that? Because that's one of the, I mean, there are many arguments as to why meat is bad. One of them is TMAO, or trimethyl amine oxide. Do you have any thoughts on that? Because they'll say, well, it's associated with cardiovascular disease, and so on and so forth. And meat.
In all the studies I've seen with it associated with cardiovascular disease, I mean, you can't really tweeze it out from insulin resistance, because I believe insulin kind of is a hormone that will turn on its production. It can come from choline. And then there's always that argument that there's like actual higher levels of TMAO in fish than any other like, meat doesn't have TMAO, it has choline, which gets converted to that. So to me, it just doesn't, when you look at that literature, that's, I think, mainly in animal models compared to the literature with insulin resistance and hyperinsulinemia driving disease, there's just like no comparison in what kind of data, when you have objective, actual, studies with hyperinsulinemia, like the, gosh, I can't remember his first name. Raven, I believe is his last name, Dr. Raven.
Yeah,
and his studies, yeah, exactly. In his studies showing hyperinsulinemia, to me, those are kind of like the golden studies where I'm like, okay, I'm gonna, and that's what I do. I focus my clinical practice. I check HOMA IR and insulin levels in all patients, because I think that the data behind that driving cardiovascular disease is much, much stronger than the TMAO, which I don't check those levels. To me, I haven't read any literature that tells me that, is going to make or break a person.
Yeah, and just to piggyback on that, the TMAO that I've looked in this fairly extensively, and one of the things, probably the things that really stick out, is you say you can't tease it out from all these other factors. And so one of the things like chronic renal insufficiency is going to drive up TMAO. And so if you've already got compromised kidneys, or gut dysbiosis will drive up TMAO. So if you have a compromised gut, compromised kidneys, and then you dump something in there that choline or carnitine from meat, you see a slightly higher level of TMAO, but it's not necessarily the meat itself. It's the fact that you already had the underlying kidney disease or gut dysbiosis that's linked to cardiovascular disease. So it's just one of these things where it's a kind of not an independent variable. It's kind of a dependent marker. What about, okay, so the big question, cholesterol. I mean, many people that go on low carb diets, whether they're carnivore, keto, whatever, paleo diets, will see an elevation in LDL cholesterol. Often that's accompanied with a fall in triglycerides, a rise in HDL, and improvements in other areas. How do you reconcile that? And do you get a lot of concerned patients? And how do you sort of deal with maybe elevated cholesterol in those situations?
That's like the biggest concern I get from patients is my LDL going to go up? I say, well, in a third of patients it does, in a third it stays the same, and in a third it goes down. So it's really, I don't know what's going to happen to you. And I say, at the end of the day, the studies are not consistent with LDL being an independent risk factor for cholesterol, because you can find these studies in healthy populations where, higher is better. And so it's a gray area where it's not everything's consistent, but what is consistent with heart disease are coronary artery calcium scores. So I just say, why don't we just get a coronary artery calcium score and see if you do have heart disease, and we can track that over time. CRP tracks much better than LDL cholesterol. And I try to bring up studies. I'm absolutely fascinated by the lean mass hyperresponder study that Dave Feldman, I believe, is working on right now. And I'm really excited to see the results of that, because I really think that will change, that would, I would think, be powerful enough to change people's perspective on it. And I think we're just myopically focused on LDL in medicine because of statin medications. And so you have that entire industry not wanting to, sway from this like dogmatic viewpoint. But I just, I always tell them that the bigger metabolic picture is much more important than one lab value. And, not all patients like that, I say that. But a lot of them, it resonates with them because, again, I have like an entire folder that like a Dropbox folder I'll send to anybody who's skeptical and say, this is where I'm getting my information from. And, people are allowed to decide if they want to, agree or disagree. But yeah, I don't know.
Yeah, and I'm very familiar with Dave. I've actually had many a steak with Dave, and then the other researcher, I think Spencer Nadolsky is also looking at that study, and I don't know if they're fully
Right.
funded yet. I know they're close to getting their funding goal, and I mean, if the assumption, my assumption is they're going to show that these lean mass hyperresponders are at no additional risk for cardiovascular disease. That seems to be what we're seeing anecdotally. It would be nice to have a study on that, and I think if it shows that, there will be people that are in that category. They'll say, put another feather in their cap and say, good for me. But I still think the critics are going to be the critics, and they're going to dismiss it because they've already dug in, and they're sort of refractory to being changed by fact. I mean, they're resistant to
Right.
fact, resistant to new data, and that's kind of what we've seen continuously. I mean, there is I hate to say this, but I think there's a pharmaceutical bias, and anything that goes against, you would need to prescribe drugs for something. We see it in a number of places now. It's considered, like you said, misinformation almost.
This information now. I'm like, all right.
Yeah, exactly. Let me ask you, do you find, so, okay, so you mentioned some of these things. So in the event, and I know not every patient will do it. I mean, you can lead a horse to water, but you can't make them drink. You can present, hey, you're obese, hey, you're diabetic. Here's what I think you should do, at least nutrition and lifestyle wise. For the ones that actually do it, what have been the results with regard to some of these markers and basically subjective and objective clinical measures?
Oh, absolutely. Fantastic. I had patients get rid of their fatty liver markers go down, inflammatory markers go down, triglycerides go down, HDL goes up. They get off of medications. I think that's kind of the biggest thing for a patient, because that's, really changing their day-to-day life, especially medications like insulin, where they no longer have to inject themselves. Really, really fantastic, fabulous results pretty much across the board. Yeah.
Yeah, I mean, I'll hopefully David won't get mad, but David Ludwig's a senior author on this carnivore paper. And so I just saw the preprint last night. And I mean, one of the things that kind of was pretty cool for me to see is that we had, of the 2,000 patients on the carnivore diet that they had data on, I think 260 were diabetics, and certain, a minority of them were type 1s. I think about 30 were type 1s and the rest were type 2s. But I mean, in that cohort of type 2 diabetics, something like 92% came off insulin, 100% came off any other injectable, and something like 84% came off all oral medications, which I think is just fantastic
Incredible.
result of coming off that much medication. I don't know if there's another intervention out there that would compare to that. So I think that's going to be something that will maybe at least get some discussion going, which I think would be really cool. I mean, one of the things, so this is and we're almost seeing, as this low carb diet has become more and more prominent, despite the people keep saying fad diet, not sustainable, going to go away. And people have been doing it for 10, 20, 30 years now. We're seeing significant, particularly with diabetes, we're seeing significant improvements in glycemic control. We're seeing people coming off their medications. And now we're seeing a shift in the goalposts. Well, it's not really about glycemic control. It's about how much fat is in your cell. And oh, by the way, eating animal fat is saturated fat. And we know that saturated fat in the blood is associated with fat in the liver, fat in the myocytes, so on and so forth. What are your thoughts on that sort of redefining the goalposts of what diabetes may or may not be?
Um, I I think that people are going to just like put up arguments just to like kind of put up arguments. I'm not too sure. Definitely overfilled fat cells have they're an underlying part of the pathophysiology in diabetes. And then you get fat in your muscles, and the muscles can no longer take up energy. And for some patients, depending on the goal, bringing down their fat intake can help them. I think it's just an individualized and personalized, a person to person thing. When it comes to weight loss, depending on your age, fat intake can definitely contribute or not contribute. And I find it really interesting, at least in my clinical experience, females, for example, in childbearing age, actually, I found tend to do better with supplemental saturated fat in their diet versus perimenopausal and postmenopausal females who tend to lose weight better with lower amounts of saturated fat in their diet, or kind of cycling fat, carbs being low in both cases, doing well. When it comes to the diabetic, I hadn't really heard that they're like trying to veer off of a glycemic control for them. Although I don't necessarily know that glycemia is the end all be all like target for that, as opposed to the patient's insulin levels, their visceral fat levels, of course, being like kind of the biggest indicator. But I'm not one to, you know, I know like Dr. Sean O'Mara measures the visceral fat levels. I don't necessarily have like an MRI machine at my expense to do that. And I hope that at one point we would have better ways to do that. But, you know, again, as your experience and my experience, you get the clinical outcome of diabetes regression and remission, just kind of reducing carbohydrates. So at the end of the day, I think we're always going to argue and debate over like the nitty gritty science and pathophysiology. But if you're getting an outcome because you've done an intervention, that's what I think matters more than anything else. You know.
Yeah, I kind of almost, you know, even though we know a lot about human physiology, metabolism, I still consider the human body a little bit of a black box, because there's so much more we don't know.
Black box, absolutely.
You know, so you put something in and what comes out, you know, you put a certain food in and diabetes goes away. That's all I really need to know as a physician. And that's all a patient really ultimately cares about. But just to sort of put another layer of nuance in it. So I don't disagree that fat in the cells can interfere with insulin signaling and lead to insulin resistance. The problem with that is, you know, they'll say it's saturated fat. Sometimes they'll point to palmitic acid. The problem with that is the palmitic acid that's circulating in our blood is not necessarily based upon what the fat we eat is. It's basically a product of de novo lipogenesis. And so really what happens is overconsumption of nutrients, whether it's fat, whether it's carbohydrates, can lead to production of, you know, palmitic acid or other saturated fats from the liver, and then that can be associated with it. So that what the vegan sort of people do is say, oh, look, there's saturated fat in the blood, therefore you shouldn't eat it. What they should be saying is, no, you shouldn't overconsume calories, and you won't generate as much saturated fat. That's really I think the pathophysiologic mechanism. But they sort of conveniently leave that little nuance out, which they're very, very good at doing. They kind of tell part of the story and then kind of infer things that aren't necessarily inferable. So that's kind of interesting there. That's you know, I like the fact that you kind of talked about the different groups, because that's one of the things we're attempting to do within this community and within this company, is trying to figure out why one person responds differently than another. Why does a perimenopausal woman respond differently than a 22-year-old male? Or, you know, is it dependent upon ethnicity and region and activity level and on, all these demographic factors, or what underlying disease you have? And so that's something I'm excited to be doing going forward. What, you know, as far as, you know, I can't remember, did you tell me, are you attached to a hospital? Are you like a hospitalist or outpatient?
Outpatient, yeah.
So you're not dealing with hospital food then.
That's probably one of the biggest reasons why I couldn't. I was like, I can't do that. I was like, this is gonna give me a heart attack if I see what these patients are eating. Really, really sad. Like, I specifically remember there was one guy in the hospital with like hepatic liver failure, and he's like sitting there with gummy bears, and I was like, that's just fructose. Like, that's stop. Somebody take those away from him. But yeah, it was really frustrating for me. That was probably the most frustrating part about doing rotations in the hospital, was just the trays on the side of the table. I was like, oh my God.
Yeah, I can't, and I remember as I started getting patients in the hospital for like joint replacements, you know, we'd stick them in overnight or 2 days after replace their knee, and you'd have to feed them. And I would always order the low carb diabetic diet, but you know, it still was a minimum of 60 grams of carbohydrate per meal. And I basically had to tell my patients, family members, hey, bring the food in for them, because they're not going to be able to feed them right here. You know, because particularly if I had them on, say, a ketogenic diet preoperatively, I wanted to continue that, because there was I saw less inflammation and better wound healing, you know, when they were on these diets. And so it was almost, you know, you just couldn't get that in the hospital. I know that Mark Cucuzella in I think he's somewhere in West Virginia, has managed, he's one of the few guys I know has managed to influence a hospital to have a low carb menu. But that's a rare thing. You know, it's one of these things where the dietitians are very defensive and defend their territory, and it's hard to get through that. So you gotta, you know, like I said, you gotta get the patients to eat themselves, bring their own food in. As far as, you know, because we often hear, like you said, you went into obesity medicine. And, diet obviously impacts obesity. I don't think anybody would argue with that, but I have found that diet seems to impact just about everything. I mean, to be
Everything.
honest, what kind of things have you been surprised at what nutrition has been able to impact in your patient population? If so, what kind of things are you seeing, wins in? Like, I know, like I see like mental health. That's something that really surprised me. I mean, it shouldn't, but it kind of did initially, but now I'm kind of used to it.
Um, I mean, pretty much any chief complaint can get better. Fatigue being one of the biggest ones. Joint pains being another surprising one. Like those are probably the two biggest things that get better when you like go towards low carb ketogenic, irrespective of weight loss. People are like, oh my gosh, I feel so much better. I don't have to take a nap anymore in the afternoon. My knee pain is better. My joint pain is better. I had one patient come to see me. She had been to like 3 rheumatologists because of her one knee, and she had a procedure on this knee, and the rheumatologists were saying that she had some type of like monoarthropathy, and she was convinced that there was something that had happened in the surgery that went wrong. And I was like, I'm pretty sure it's the surgery, but she was kind of immobile, and I got her kind of onto more anti-inflammatory foods, got rid of the sugar, got rid of the grains. And she was like, of all the doctors I've seen, your recommendations helped me the most. And again, so like not even knowing the root cause, you can fix these things just by changing what you eat. Reflux, better sleep. Let's see, like mental clarity, mental focus. As you were saying, mental health, I'll see get better. Reflux, I'll see get better. Abdominal, weird, vague abdominal complaints, I'll see get better, like bloating. Bowels can be hit or miss, as you know, when you change your diet. Sometimes they get worse, sometimes they get better. A lot of people have SIBO, small intestinal bacterial overgrowth, and they're not aware of it. And I'm convinced that's from like ultra processed carbohydrates. You kind of starve those out and things get better with that. And sometimes you need to add some extra things to that. But it can be really overwhelming how patients come back. I didn't even know that they had certain complaints, and they're like, yeah, that got better, that got better, that got better. Anxiety being another big one. I know depression too, but even more so with anxiety. I had personal experience when I finally like got myself into a state of nutritional ketosis. My anxiety levels got so much better and my memory got so much better. I was in the hospital as a resident, and I finally like stopped needing to write down everything that a patient told me while I was doing an intake, because I could just recall it. It was incredible. Like, this is amazing. And then getting to see that in my own patients was also incredibly rewarding. So yeah, like plethora of things get better, but definitely the fatigue and the joint pain are the two biggest ones that still shock me. And people are like, yeah, because they won't even tell me that they get joint stiffness in their hands, and then it's just better. It's pretty cool.
Yeah, that, in the data we have, and we have data on thousands. I think I did a survey, I got like 12,000 responses, and the top 4 things, obesity got, clearly obesity was improving. We were seeing joint pain, mental health, and GI issues were the top 4 things that we saw. And there was a whole, dozens of things underneath that, but those were the 4 most common things. And I think part of that's because they're just common problems. I mean, a lot of people have joint pain, that's kind of normal aging, so to speak. And I would say so normal. In fact, there's been a couple of nice literature or studies in the literature on orthopedic joint pain improving with low carb diets, which I thought was pretty neat. They're seeing a decrease in inflammatory cytokines being, sent out by the synoviocytes based on insulin. If insulin's high, they tend to produce more inflammatory cytokines, and so when you lower insulin, that gets better. And so I think one of the things that really frustrates me, probably the least favorite thing I like talking about, even though it helps and it's so common, is obesity, because you have people dug in saying, a low carb diet's not the only way to lose weight, and no one's saying it is. But what I see is all these other things that are improving. Like you said, irrespective of weight loss, people's knees stop hurting. And I think that's really, really fascinating. And I think it's underappreciated and under talked about. I've been one of the at least one of the few people that's talked about it. More people are starting to recognize it now. But I think that, if this is a battle to win, and I don't know that it necessarily is, but when we're trying to make our point, I think we should focus not just on obesity, because
Absolutely.
There's a lot of skinny rheumatoid arthritics that are super, they're frail, and they
Yeah.
are getting better by switching the diet. It's not about obesity all the time, like, you know, what many people will say it is.
Like the scale can lie. So as a vegan vegetarian, I got to kind of the smallest waist size that I've gotten to, like a size 6'8". And I kind of ballooned up when I went back to everything in moderation until I found low carb and got back down to like a 6'8". But as like a low carb ketogenic size 6'8", I was like a solid like 10 to 20 pounds heavier than as a vegan vegetarian. And so, you're talking about like bone density when it's, non-fat weight. And that's really, really important. Bone density and muscle mass and muscle density. I'm clearly like, more muscular eating a more animal-based diet than I was eating a plant-based diet. And, you look at sarcopenia, which is low muscle mass, and osteopenia, low bone density. These are like silent epidemics in our elderly, or as people age, is incredibly common. I would do, in-body scans, and even people who are normal weight, normal BMIs, like their percent body fat is totally out of proportion to their lean body mass. And is a really big problem that I don't think a lot of doctors address, but nutrition can fix that. And so, you get to the point where sometimes you want the scale to go up because you want to be putting on the muscle mass and you want to make sure that your bones are nice and strong and healthy. So, yeah, obesity shouldn't necessarily be, or weight shouldn't necessarily be the end target. The scale can lie,
Yeah, I think replacing obesity with sarcopenia is not much of a win, and in some cases it might even be worse. There's a question here about disordered eating, anorexia, bulimia, binge eating disorder, so on and so forth. Do you deal with much of that or see any of that? And do you find that shifting diets helps that if you do?
I had one patient who came to me. She was bulimic and, struggled with binge eating. And she was also working with a dietitian who wasn't happy that I put her onto like a low carb ketogenic lifestyle. And the patient herself was like, I haven't even wanted to binge since I started eating this way. I haven't wanted to purge. And she was kind of at a little, crossroads because the dietitian was like, well, this is a restrictive diet and you really shouldn't be doing that. And I was like, listen, you got to do what you feel in your heart is good. I love that you haven't been doing this, or, you haven't binged, you haven't purged. And to me, that's a win. She's also feeling better. She's also losing weight. She also had all these like non-scale victories. So I do think that there's a role for that in the low carb community. It's a little tougher when it comes to anorexia, because a lot of true anorexics have a fat phobia. And I haven't really dealt with that much clinically. But I can say for, outside of bulimia, binge eating, I've seen, plenty of patients get those symptoms significantly improve because they just don't have the craving for it anymore. Because it was, the ultra processed foods that were triggering their cravings. And, we talk, one of the first steps in obesity management is cue removal. It's one of the most powerful things that you can do is remove these food cues from your face. So I say, you got to go home right now and clean out your pantry. Like, and, a lot of times people are like, oh, well, my grandkids, I say, okay, well, lock it away for them, but know that it's not good for them either. Like, do you want them to, be a patient of mine 20 years from now? And it just gets them thinking. But, cue removal is incredibly powerful. And it becomes very obvious when you talk to somebody what their trigger foods are. Like, so you get those out of their face, and the obesity problem gets better. But to me, restricting junk food isn't restricting food. It's just giving your body proper nourishment. So it's a nuance, but I wouldn't say it's restrictive. I would say it's actually just feeding your body real food. Even if you're still including like carbs in the form of potatoes and sweet potatoes, those are way less harmful than potato chips. So, there's a level of harm reduction, and you just kind of work with a patient to see how far they're willing to go when it comes to those foods. But eating disorders are incredibly common, especially in high schoolers and young children, and it's incredibly sad. There was a point in my life where I also, struggled with bulimia for a little bit in high school, and learned how to binge basically. And I eventually, that was eventually caught by my friends really helped me out of it, and I eventually kind of grew out of it. But the binge eating component really kind of stayed with me, and that was a battle that I eventually discovered cue removal, and that's how I did it. And it's kind of like a demon inside of you, like to this day, if I have a stressful day, I will go to my pantry and I'll open it up and I'll be like, what can I eat? And there'll be nothing there, and so there's nothing I can do, and I just walk away and say, okay, it's like we got to go find a different coping mechanism for stress. And having other tools in your toolbox and kind of getting to the nitty gritty as to what is triggering the binge. What other tools do we have in our toolbox to deal with stress and cope with stress? And those become important to cultivate. And I think for the younger population, for parents, teaching their children, coping mechanisms, because we live in a really stressful environment, and especially with social media, it's not getting any easier, and food is an easy, cheap outlet for that. And so, I try to, guide patients in that direction. Other coping strategies, removing the cues, and, seeking help, somebody you can talk to, whether it's a therapist, a good friend, a priest, a rabbi, whatever floats your boat, just not making it the food.
That's some good advice there. And I think it's having a backup plan, because if you know these things are going to happen, have a plan for that. Well, unfortunately, I've got to go here in about 2 minutes, and this has been so wonderful. Thank you so much, Christine. Where can folks go to find you? Website, social media, and then maybe we can get you come back in down the road if that'd be
yeah, fun. Absolutely. Mainly on Instagram or Facebook at Doctor's Dish is my tag, so you guys can find me there. Spell out the word doctor with an S at the end, and then dish. Be happy to talk, and thank you so much for having me. I'm like such a fan of this community, and it's like an honor to be here, because I've learned so much from this community. Obviously things they don't teach you in school, and I wouldn't know where else I would get that information than just hearing all of your stories, which have moved me dramatically. So I'm really thankful for you, Dr. Baker, for even having this community available, so that I can say, just go look at the success stories. People have done this, people have come out of this, like you're not alone in this. Very powerful stuff.
Yeah, it's amazing, and kind of crazy thinking doctors learning from their patients. That's just kind of a crazy concept these days, isn't it?
Crazy concept, but that's how I work.
Okay, thank you so much, guys. I got to run. We'll see you guys back tomorrow. Okay, take care, everybody. Bye-bye now.
Take care.